Thank you, Lucy. As Lucy was saying, she was very modest. She was actually one of the vice president of AMSC. We do encourage young and junior doctors as well as medical students to come on board, because they are going to be the leader for this organization next. I'm excited to be involved in this training session. And tonight we focus on the obstetric and gynecological training. Most of you might know that most of the specialty training are very competitive, and that's including ONG training. But bearing in mind, most of the people who are keen to be in the training would eventually get their training spot. So do not get too nervous, do not get too disheartened if the first time you couldn't get in. Tonight, instead of going through all the official talk from the college website, which we have in here, where you can look through all the official training requirement, I thought the best tonight is to get two of my good, brilliant star lieutenant, James Brown and Hillary, who has gone through the training program with flying colors, but they all have their different ways of going through it. And they will tell you what, from their perspective, what they would have done if they were to go training again. And I will let James Brown, our salesperson, to take the floor.
Great. Okay, so I'm just going to give James, I'll give you control over the slide.
Cool. All right, looks good. Okay, my name's James, one of the ONG registrars out at Westmead Hospital. So given that the approach is what I would have done if I went through again, the story about this presentation is actually something I went through myself. So in about my second year of training, I tried really hard to quit this job and went through a whole process of things to try and work out if this is what I actually wanted to do and if there's other things that were better suited to me. So it was probably poorly timed, but if you take this model back to the very beginning of when you're looking for your jobs, I think it's way more useful. So this is the trial and error that I went through that eventually led me to where I am. And I just wanted to walk you through what we came up with. So, next slide. Cool. Sweet. So, remember that medical school, you're not meant to come out of it fully packaged, right? So, it's only what, 4, 5, or 6 years, depending on where you go. You're not going to know everything you need. It's like coming out of high school and picking the right degree. It's not really possible. So, you can't expect that you'll be fully formed at the end of it, right? What it does do is give you a whole sense of the options that you have as you move forward. And a lot of the options you don't even think about, all these non-clinical and digital health and all this sort of stuff. So your ultimate ambition in medical school is not to pick one thing, but to find out how many things there are that you can consider and try as you get through this career, right? Because once you leave, the science is the easy part. The actual navigation of these pretty convoluted career systems is way harder. So it's really tough, and there's no real system that will guide you through it. It's all fairly opaque, and it's a lot of word of mouth. It's a lot of self-initiation, and you just have to find a pathway through it that's fairly structured so you don't get lost and bogged down. The first thing to know, as if I was a medical student these days, the first thing I'd be worried about is all the bad press that medicine gets. I've got to be honest with you, I've tried enough jobs before I did medicine, and I've seen enough of my friends who are now getting into middle-age sadness that medicine's actually a really, really good job despite all its shortcomings. The most important thing is you won't be bored and you won't be poor. It's stimulating, it's well-paid, it's secure, and ultimately you're respected even if you're not a respectable person, which is a pretty sweet gift. But becoming a doctor is tricky, and it's getting trickier. What's happening is because of the increased supply of doctors over time, the way to differentiate type A into people has become more and more complicated to try and keep it fair. Whether or not it's a fair process, I can't really tell you, but you will have to jump through more hoops to demonstrate your quality if you want to get onto a training program. Okay, so you want to be efficient about this administration. Don't get bogged down in it, and work out the most streamlined way to meet your requirements so that you can stay in the enjoyable parts of this job. So in terms of a plan, you're ultimately unprepared, right? So AMA found that 38% of interns didn't believe that medical school prepared them for being a doctor. right? But that isn't the science part they're talking about. It's more that you aren't taught about the job or how to move forward in a career space during medical school. And so I think that that's why people feel unprepared when they leave medical school. And not only that, but if you're not taught what the job is, of course you're going to find 1 in 6 people who, if they've given their time again, wouldn't do medicine, which is not really necessarily an indictment of the career itself, but how much we can demonstrate what it actually is once you get out. But the only way to know, because it's such a hyper-specific experience, you have to go through it. There's no way to predict how the job will be for you because there's no reference point beyond your adaptation. So you need to talk to other people who've been through theirs and try and see where the parallels are with what you've gone through or what you're going through. So to keep things short, because we don't have much time, I'm going to go through a pretty practical plan about how you cut down your options and hopefully find the right thing for you. So the first thing to do is find the boundaries, because if you don't know, if you think that everything's infinite, you're really going to have a hard time starting. So you really need to put a fence up. There are a lot of specialties, there are a lot of paths, but ultimately they're finite. You probably don't know them all. Medical school shows you the core aspects of the job, but there is so much more. There are some good resources out there that I would normally recommend, which is Map My Career, which is a Health New South Wales initiative that goes through all the different specialties, and also a thing called the AMA Career Pathway, which again, break down all the clinical specialties into amount of time to train, competitiveness, subscription rates, average age, all that sort of stuff to give you a general sense of what they are. This is the beginning of your map because these are the boundaries. You won't be able to read these, but this list is the list of all the specialties that exist in medicine, right? And it goes on forever. So there's lots of different permutations, and it's a lot of them, but it's still finite. So you've got a sense of where it ends, right? And if you think about that, there's even more. So you can think of things that cross over, or there's some blending of non-clinical work as well at the same time. So you have to kind of look at the other aspects of it that make it different for you. So things like being part-time, being in a different location, how many hours you're going to do of each part of the job are also things. But still, the majority of you will be looking at something clinical as a starting point. You're obviously very aware that some of these are harder to get onto than others, but all of them are really becoming more difficult over time, but not impossible, right? So if you are good and you play the game, you will get on. It's not an impossible filtration process, right? And this may actually influence it's not actually an unreasonable thing to choose to go through something that's easier to get onto than something that's harder if it's going to take you 8 years versus 2 years to actually get on the program in the first place. Okay. So for you to be able to work through this process of all breaking down what things are best suited to you, you need a recipe, right? So taking it step by step makes it more manageable. Now, you're not going to be able to make this because you haven't done the job yet, but I can tell you as someone who's done this job and been in various states of satisfaction and dissatisfaction over time, these are the elements that I had to consider, right? Ultimately, it requires internal, personal reflection, right? Specialties is only one thing, right? You're going to have to ask some really hard questions about how you're going to define and design your life moving forward, of which your actual content of your job is only a partial importance, right? So here's a little recipe that I use, right? And it takes into account both the job itself, but the life that you would like. There is no point doing medicine if it turns your life into something you don't want. You need to leverage the security and the financial security to actually allow you to design a life overall that is what you wanted, right? So this is the recipe, right? So it looks a little bit more complicated, but I'll go through each in sort of detail, right? So interest, goals, strengths, location, money, family, flexibility, and equation, resilience, age, and the future, right? So the important thing to note here is that interest is only one, right? There are very, very few people in medical school who come into the degree saying, I just want to be a cardiothoracic surgeon. I know the one guy from my year, and he still wants to be a cardiothoracic surgeon, but beyond that, it won't be a motivating force for the majority of people. There is more to your plans, right? So it's easy to think of it from a Freudian perspective. So you might be a parent, you might want to be a parent, you might be caring for your parents, you might owe your parents money, you might want to live near your parents, you might want to live far away from your parents, and you might want to make your parents proud, or you might even want to make your parents disappointed, right? So there are different parts of your life that will guide which of the career options are more suitable to you, beyond the very fact that you may be enamored with respiratory medicine if that's your jam, okay? Cool. The ultimate thing is the reason why we put all the other non-medical stuff in this recipe is that because your life gets consumed so totally by this job, if you don't prioritize something, by definition, you're going to be sacrificing it, right? So life is full of priorities, right? And not all of them are compatible with your first choice career, right? You will also have to choose to sacrifice things. So as long as you can knowingly understand that you're sacrificing something, that's a far more sustainable way to design your life than sacrificing something by neglect, yeah? There are only really a few people who don't regret sacrificing their personal life for the job, and the other ones are usually just honest. Cool. So explaining the recipe, let me see. So I'll go back. So when I talk about interest, that's easy. That is the actual clinical aspect of the job you're picking, whether that's bones, whether that's ONG, whatever, right? The next question is about goals. Who do you want to be? It's ultimately the zenith of medicine is being like an all-purpose rural GP, but you might want to be some academic professor. You might want to be someone who has a foot in administration. You might be someone who wants to have a thriving private practice. None of these are better or worse than others, but your ultimate goal of what your life looks like is important to consider because your specialty will be a pathway towards that. Another thing to think about is what your strengths are. It's because you're type A and you can modify your behavior to meet most requirements, you could probably succeed at the majority of things. But if you choose something that you don't have a natural aptitude for, you will be exerting more energy to keep up with others who do have a natural aptitude, right? So if you go towards something that it is your natural aptitude, you're swimming downstream against others and your life will be so much more easy and you'll be able to exert energy more efficiently to do other things that you like. Then in a more practical sense, location is important. Some jobs are very hard to get nowadays in a metropolitan district if you want to work in the inner city of Sydney. If you want to work really completely different, where you eventually want to end up should influence somewhat what you choose to do, right? Same with money. Again, I said before, you won't be poor, but if you have certain aspirations for how much money you want to make, right, then you will need to make sure that that job is sustainable to achieving that money and how much money it will take to spend to get there. A notorious example would be something like maxillofacial surgery or orthopedic surgery, which requires you to output a lot of money, but arguably will make you more in the long run. So you have to understand the cash flow of training. Other things like family, whether you want to be close to them, whether you want to have a family, should also be somewhat compatible with the career that you want to choose. Another thing that people underestimate is flexibility. So once you get money and once you get trained and once you achieve your goals, the ultimate thing that you're going to want after all of that is now finally some flexibility. But what you might have done is cornered yourself into something that won't allow you to be flexible. Yeah. And then the equation. So when you work out the stuff above, you need to work out what you're willing to sacrifice to get something else, and you need to make that rigid. So you can't say to yourself, well, I need to get onto surgery. You need to reasonably say, well, I'll either spend 5 years or you spend 10 years if you really want to get onto it. And you need to keep yourself to that. Because once you start slipping, there are people who get caught in this loop of probably never, ever getting on, but not having the self-reflection to realize that they've surpassed their own expectations. Then you have to be pretty honest about a few things. Are you resilient enough to do some of the jobs that you want to do? I'll be upfront is that there's a lot of jobs that I probably am not resilient enough to do, hence I have not done them. Yeah, not everyone's the same. Some people have more ability to wear and tear than others. You have to be honest about what you're doing. Please don't bash yourself up for a job that you are not suited to. It's only going to cause misery. Your age also needs to play into this a little bit. If you're entering medicine at a later stage, then you need to be realistic about how long it's going to take for you to get to where you need to be, because you're on a little bit of a shorter timeline than others. And then you can think about what medicine is in the future. Yeah, cool. So if I was you, if I'm in your position, you need to start looking at the domain of your life. How is your life different or the same to the person next to you, right? So are you, for example, an international student? This is critical to when you're trying to apply for a job, right? Because you don't have access to easy internships. And if you don't have permanent residency, it's very, very difficult to get certain competitive jobs for extremely unfair reasons, if you ask me. Are you a mature age student? Another thing that plays up a lot is, are you in a relationship with another doctor, which can make things super complicated if you both want to do hyper competitive, protracted training programs. The other thing is, for whatever reason, you may be in more debt than someone else. So doing a training program that requires a lot more money to be invested in it is not going to be a sustainable choice for you for a number of years. And are you able to move around the country? So if you want to be a glorious pediatric surgeon, your training network arguably will include not only Australia, but New Zealand and Singapore, and you'll have to move on a potentially 6-monthly basis. You may not have the facilities or the flexibility to do that. And if you're financially supporting others, it goes back to whether you're able to sacrifice some income in the short or the long term. And then you have to ask some really hard questions about yourself. What are some non-modifiable personal limitations that you have, right? Can you remain sane and work 70-hour weeks? Can you work night shifts? Some other people go absolutely mental you doing shift work, and other people hate doing exams. And there's some exams that are purely arbitrary and you will fail them regardless of your knowledge. How will you mentally deal with that? Being on call, for example, is something that can be miserable for a lot of people. And another thing is, can you be satisfied while getting stuck in the same job, spinning your wheels, while people around you potentially progress faster? And you have to also assume that in some positions, you will have to tolerate a far more severe form of criticism than other jobs. And are you able to tolerate that? Because ultimately, yes, the system shouldn't be like that, but you have chosen to go through it. So I'll skip this just because we're short on time. So doing some examples, right? So let's say you've got a basic med science graduate, domestic student, 27 years old, wants to do surgery. Goal is basically to have a small private practice and a bit of public service work. The strength is that they're a good public speaker, but is keen to stay in the city. Doesn't have really any money issues, has a lot of family in Sydney, wants to sort of stay there, and flexibility likes the occasional weekend. And what she's decided is she probably wouldn't do more than 2 or 3 SRMO years, right? But her resilience is good and she hasn't got particularly interest in the future. So looking at that, if you want to do general surgery, that is a fine recipe, but there are a few limitations, right? So difficulty at planning a family, particularly if you're starting at 27 years old. But a good thing is, if you stick to your equation of 2 to 3 SRMO years with a backup plan, that's a far more reasonable trial than if you go, well, this is the only option for me. You have to be realistic. Second option would be Andy, who's an international student, but he's not a citizen, right? So 28 years old, interested in sort of GP or pathology. His goal is to become a citizen and then a local GP that's well respected and well regarded. He's good at research, would work regionally, but a little bit reluctantly. Family's helping with money, but a lot of debt due to the international student thing. Family lives in Singapore and has no partner. So flexibility is not really a priority and is willing to work pretty damn hard for 10 years, right? Given this type of fellow, while the deck is stacked against him, his expectations are very reasonable about what he wants to do, despite there being a lot of impediments that other people don't have to suffer through. Yeah. And then you've got 26-year-old at graduation, interest in ONG and psychiatry, and all this sort of stuff, right? You can go through this bit by bit, and I would recommend you doing the same thing, right, for you and seeing you'd be quite surprised when you put this on paper. Ironically, this is me. Yeah. Cool. Now, if you were to fill it in for yourself, you can write this down, you can watch it later, start working it all out. And once you map out what your priorities are, you'll get a better sense of what's more suitable to you and what's not. That's the first step, right? Work out what exists, work out what you can do. Next step is you need to make the shortlist. So what I would do is you go through Map My Career or AMA Career Pathway, and you, instead of picking the things that you want to do, rule out all the stuff that you would never do. Yeah, and you have to consider somewhat competition at this point because you would not suffer through 10 years of fighting it out for some things. So it's better to rule out than rule in at this point. Then once you've done that, use those categories to define what you want and then reevaluate the shortlist in accordance with those goals. That should hopefully make the list shorter. And then you go to phase 2. This is where it gets a bit difficult, right? So people will the thing about medicine is none of this is written down. Medicine is strangely an oral history of itself, yeah? So people over time will make the mistakes for you, but they won't tell you their mistakes. This is literally how evolution works, right? People won't tell you unless you ask them, and you need to be the one who approaches them. The good news is, if you do, people would love to tell you about all the mistakes they've made in medicine, right? They're really generous with their time and their insights, and they will almost certainly be honest and open if you are interested and inquisitive. Right? I can tell you right now, it's my favorite part of the job if someone comes up and asks for advice with specific questions, because it allows me to reflect on what I've done and what I might be missing, right? So my best example is a professional wrestler called Dallas Page, who professional wrestling is a dumb job with a very short lifespan, and he chose to do it in like his late 30s. And the only way he did it and he became successful is he used to pester people for advice all the way up, and it accelerated his learning and made him get better very quickly. And so as you talk to others, it's not just the doctors that you're talking to, but your family. So if you work out what you kind of want from your life, you also should know what your partner wants from life and what your family's expectations of you are. And you can also talk to your peers to see if there's aspects that you haven't considered. Make this an open and transparent process. It's the only way to maximize your learning. The next thing, once you've done that, when you find your shortlisted field, go seek out people in that field. And I'm not talking about like Order of Australia medal winning professors. It's the people on the ground, the registrars, the fellows, the people who are wanting to do the job. They're the ones who you talk about because they're the ones who have the most current perspective of what it's like. The next thing, if you want to work out logistics and you don't feel like you're getting the right information, you can actually speak to the colleges themselves about getting more info. But importantly, it seems like a lot, but there's no real rush. Yeah. So I think it's frozen. Previous. Yes. So there's no rush. So we have at our hospital someone who's still working, who's very still intelligent, who graduated from medical school in 1963, right? So they've been a doctor for over 50 years, right? And they're still practicing. So you spending 2 or 3 years to find the right thing for you is a way better investment than spending 50 years doing something that you hate. So try things out, give it a go. And if you're diligent and you know, like if you're realistic about what you expect from the job, you're much more likely to succeed. Same thing goes that if you have any questions, concerns, whatever, and you want to know, feel free to email me anytime. That's it. Well done.
Thank you, James. That was really helpful. I think as a junior doctor as well, that's definitely something I really liked, your kind of process of thinking things through. And for the people online, feel free to unmute your mics and ask questions or send through questions on the chat and I can ask them for you. Anyone? If you think of something at the end of the talk, you can also ask that.
Cool. Go for it.
Cool.
Yep.
Thanks, James. All right. So I'll hand over to Hilary now, who will give us a bit of a more O&G focused talk. So give me 1 sec as I give Hilary control. There we are. Go for it, Hilary.
Thank you. So I'm Hilary. I'm one of the 5th year registrars at Westmead. I'm currently at Auburn this year. Interestingly enough, James and I didn't coordinate our talks, but our content's actually very similar about how we came to our decisions. So this slide is just to for everyone to have a think about the journey in medicine in O&G because it is quite long, and every time you think you're done, there's always something else to be done. So I'm going to give you a brief overview on why you should do O&G, how you can get onto the training program, and then some tips and tricks in general. So this might be well before all your time because I'm a bit older, I think, than most of the medical students now. But when I did my HSC exams, my English curriculum, I had to do journeys as part of it. And when I was writing my HSC essay, I always argued that it's the destination that matters, not the journey. That's definitely not the case in medicine and definitely not the case in O&G because it really never ends. So you always think I just have to get an SRMO job, then you have to get onto training, then you pass your exams, then you do fellowship, then you get a consultant job, and that's the end of it. But it really isn't. So you really have to enjoy the process because that's the whole life essentially. That's the process, not the destination. So why O&G? This is more for me. And if you look at it, it's actually very similar to the points that James had in his talk. And this is not coordinated either. So these are the reasons why I picked O&G. So in general, you should try to do what interests you, but it isn't the most important thing as, oh, sorry. That was me. Sorry. But that's not the only factor. So that's why there's a few other things in there as well. And when you're choosing a specialty, it's not the really exciting things that you do every day. You've got to think about the bread and butter. So for example, if you're doing endocrinology, your bread and butter is actually diabetes, not some fancy thyroid storm, for example. Or if you're doing general surgery, if you work in a public hospital, you probably have to do ASU on call. That means the majority of your work is actually going to be appendixes, gallbladders, abscesses. Again, not the exciting and fun stuff. But for me, I think obstetrics and gynecology, there's no real bread and butter unless you consider all of pregnancy as your bread and butter. but every patient, every pregnancy, every baby is different. So I genuinely think O&G is probably better than every other specialty because there isn't the boring stuff that I think there is in everything else. Lifestyle or lack thereof, if you should so choose. So although O&G has a reputation for having a horrible lifestyle, I don't think this is necessarily true. And this is kind of the general theme of why I picked O&G, because you can choose to be really busy. And for the medical students that weren't around at the start, Dr. Chua was telling us how busy he'd been in his younger years and how little sleep he'd gotten. But you don't have to, if you pick an O&G as a career, you don't have to do on-call and deliver 17, 18 babies a week or 8 in a day. You can choose to just do ultrasound, for example, or office gynae. You can work part-time, you can job share. It's all very flexible and it's all completely up to you. And money that James touched on. So we all have to live, and it would be a lie to say that finances don't affect our life and our life choices. And currently, for example, if you're living in Sydney, not eating smashed avo on toast and saving all your brunch money is not going to buy your house anytime soon. So we all have responsibilities and families that we have to take care of, and money can play a role in determining your specialty choice. And O&G, because a lot of it is procedural based, you can be relatively comfortable that you can support your family without any concerns. And then location. So where you work determines where you can live. And some specialties now are so oversubscribed that you're almost definitely not going to be able to find a job in any metropolitan area. So you're going to have to work somewhere rurally or regional, potentially for 10, 20, or maybe the rest of your career. So this applies broadly as well to if you have any aspirations to work overseas, like Singapore, Canada, or New Zealand. There's specialties where you don't really have the freedom to move around. So for example, radiation oncology or medical oncology, it's not really feasible to work privately and also in rural or regional areas. So if you pick O&G, for example, you can work in the city and there are still jobs in cities. You can work regionally, you can work rurally, you can also work overseas. And then if you're interested in volunteer work, it's one of the specialties that MSF will take, for example. Family. So again, despite the reputation for O&G being tough on families, for a procedural and like a surgical specialty, it's probably the most family friendly. You can really customize what you want to do in O&G to achieve the lifestyle and the workload that you want. You can definitely have children during the training program, and that's the biggest part of the reason why I picked O&G in the end, because you have the ability to work part-time. You aren't really penalized for taking time off, like maternity leave or going back part-time as well. And then finally, overall, O&G is very, very flexible. So because it's at the moment anyway, it's not oversubscribed. You have so much freedom and choice of how you want to work, where you want to work, private, public, VMO, staff specialist, all those kinds of things. So moving on to how to apply. So as Dr. Chua, I think, had mentioned earlier, it is all online. And I think one of the good things about Randscope is it's very transparent. So the whole selection process is all online. There's a point system. Everything is clearly set out. And they also try to give you advance notice of if things are going to change the next 12 months so you can plan ahead. There's a standardized interview process, and then the allocation in terms of jobs is also very fair, unlike I think some of the other surgical specialties as well. So go on the website. I'd advise everyone to look it up early if you're interested, because some of the things on there, especially in terms of the CVE points, you have to plan 12 to 18 months ahead. And just a very quick overview on the Randscope training program. So in general, it's 6 years total. So that's 4 years of basic training and then 2 years of advanced training or fellowship. It's built into the training program. There are metropolitan and regional training sites, and it also covers Australia and New Zealand as well, and you can apply for both. There are only, happily, 2 exams for the whole training process, unless you subspecialize. So there's no entry exams, there's only exit exams, so 1 written and 1 OSCE that you that you have to pass before you start advanced training. And then there are you can subspecialize in O&G as well. So it's 3 years of subspecialty training. but you can start that in year 5. So potentially you could only add 1 more extra year to your training time. And there's 5 subspecialties. There's gynaecology, MFM, which is maternal-fetal medicine or really high-risk obstetrics, obstetrical and gynecological ultrasound, reproductive endocrinology and infertility, and urogynecology. So a typical week for me, again, we're having a chat about this earlier. This is, I have to be honest, an atypical week for ONG, but a typical week if you're at Auburn Hospital. So usually the work hours are 8 to 4:30. Sometimes I have to come in at 7:30 to do a ward round before my morning operating list, but that's quite rare. We have handover at 8 o'clock. We do ward rounds for maybe 20 minutes, half an hour, and then we start either the morning antenatal or gynecology clinic. And then at the same time, there's usually at least 1 gynecology or cesarean section list during the day. And then all the registrars take turns covering birth unit and then consults for the ward or emergency department. And then at Auburn, the rostered overtime is average of probably 8 hours a week. It's a mixture of evenings or weekends, and there's also offsite on call at Auburn, which I think is an excellent thing because it gives you the experience of what being a private obstetrician is like. And then we'll take turns rotating through nights during 1 week out of probably every 2 to 3 months. So just moving on to the difficult part of the job, this is probably the non-PC version. But for me personally, the bad outcomes are definitely the most difficult and worst part of the job. So it happens to everyone, and it's sometimes and often unavoidable. I've had a consultant tell me something that he was told when he first started training, that by the end of each obstetrician's career, there will be a busload of children with bad outcomes as a result of your deliveries. And it is not always avoidable. It's very hard to accept and deal with, even when it's completely out of your control. And it's, I think, worse than other specialties because obstetrics is unique in that you sort of have 2 patients. You have the mum and you have the baby. And generally your patients are young, fit and healthy to start with. So it's much harder to accept when they have bad outcomes. Difficult patients, so I don't think many people will say this out loud, but it is, pregnancy and childbirth is a very emotional and very emotional time for everyone involved, and emotions can be quite high. They can often be urgent or very emergent situations, and patients can deteriorate very quickly. So often you have to deal with the mum and the dad, and often extended family like sisters, mothers of the patients, mothers-in-laws of the patients, and then fathers-in-law. When something happens, and in regards to a pregnancy, everyone feels like they have a say. So often these patients are very anxious, they're worried and or angry, which can make it hard for you to deal with. Limited resources is also a hard part of the job that you don't really think of sometimes, but in some hospitals or regional settings, patients can receive different care because of the different or lack of resources that they have. Something that people don't even think about, but for example, private obstetrics or Auburn Hospital, when there isn't a 24-hour on-site obstetrician, in an emergency, some patients can have, I guess, a delay or don't receive the care that they may necessarily need because there isn't an obstetrician or operating theatre team on site. In regional settings as well, there's no subspecialty services. They also don't have some, say, MFM ultrasound or diagnostic procedures available like amniocentesis. So I worked in Dubbo 6 months as part of my training, and they didn't have a public gynecology clinic there. So the patients just went without, or they travelled sometimes all the way into Sydney just to, for example, maybe have a pap smear done. They also didn't have public termination of pregnancy services in Dubbo. The closest place they had that offered it sometimes was Orange. So patients in Dubbo who had pregnancies that weren't exactly planned or wanted had to make their way to either the Blue Mountains or even Sydney to have a termination. And so there were actually a lot of women who just continued pregnancies because that was the easier option for them. The final thing I thought was one of the hardest part of the job is the long training program. So 6 years is, well, I'd say quite long, and it's during your arguably best years when you're supposed to be out having fun with friends, meeting partners, getting married, having children, and your training is smack bang right in the middle of it, and it can hinder your attempts to achieve those things. So moving on to the best part of the job, it's also the patients. So I can't think of any other specialty where you get to know your patients as well, except maybe GP, which I will make a comment about later. But especially in obstetrics, you really, really get to know your patients and become close to them. And even now, just being a registrar in a public hospital setting, I've seen patients come back with their second baby where I've been involved in their care of. And childbirth and pregnancy is a life-changing, momentous occasion, and you really get to share it with them. And my favorite part is always when the dads cry at the delivery of their babies. It's honestly really the nicest part. And there's no other specialties where most of the time the patients are so happy for you to cut them up. And this is obviously in relation to cesarean sections, not gynae procedures. Another part, the best part of the job is about obstetrics and gynecology is that it's obstetrics and gynecology. You get to do both. So it is a cliche to say this, but it is really the only specialty where you can manage the conditions and patients medically and surgically. And then again, going back to career choice, you can choose just to do medicine only. You can be an academic and you can just do research, for example. So within training, there's a research stream that you can choose. And then you can also just do ultrasound. You can just operate. You can, in just operating, you can do general gynae. You can do gynae oncology. The world's your oyster, essentially. You can pick and choose whatever you want to do. And then flexibility. So again, going back to everything I've mentioned, timing of your work, full-time, part-time, job share, where you work, regional, city, private, public, VMO, staff specialist, you can all choose these things. And then 2 exams, in my opinion, it's probably one of the best things about ONG training. There are no entrance exams as well. And the exams that you sit are relatively early on in the training. So you may, unlike say surgical specialties, you're not stuck at the end, sitting year and year trying to pass exams and not being able to progress on with your training. And I would also argue that the ONG exams probably isn't the hardest exam out there in comparison to other specialties, for example, anesthetics. So just some comments on how to be a good candidate. So if you can, try to pick the specialty that you want to do early. So earlier you decide, the more work you can put in that's specialty specific, and the quicker you can get on or achieve the goals that you want to. So this starts from being a medical student. So you kind of need to pick the hospital you want to intern at depending on what specialty you want to do. So for example, if you know you want to do pediatrics or GP, then you really should try to pick a hospital that has a pediatric term and not just whatever is closest to where you live or where your friends are going. You can start doing research early that's specialty specific, and then you can work with and get to know the right people. So the PVOGs, that the website I put in the corner, is the Pre-Vocational Obstetrics and Gynaecology Society for Australia and New Zealand, and it's targeted at medical students and interns and residents who are interested in ONG, and they have a lot of resources and advice on there to help people get onto the training program. Work smart, not hard, but also hard. So if you can decide your specialty early, they all have CV criteria and points that you can achieve. So try to target that specifically. So attend the conferences that they want you to attend, do the specialty specific research rather than just any research opportunity that comes up, because that may not count later on when you apply for the training program. And you do still have to work hard though to differentiate yourself between you and the rest of the crowd, which is getting larger and larger. So go above and beyond just your job description. So if you can, come earlier, stay later, help out even if it's not within your job description, that kind of thing. And then do your job. And it's really as easy as it sounds. And it's very surprising to me, but in the past, I've met many interns, residents, even unaccredited registrars who say they want to do a particular specialty and in ONG as well, who won't do the most basic things like come to work on time, do a ward round, write scripts or discharge summaries. So it doesn't matter if you can do a cesarean section unsupervised as a resident when you won't even do the most basic things like write a discharge summary, because that is noticed and it won't work in your favor. And then lastly, find something that you enjoy. So there's a difference between those who really enjoy what they're doing, those who work hard because they have to just to get onto a training program. The enthusiasm and effort often flags early in those who don't enjoy it, and it's much easier for you to work hard and long hours if you enjoy what you're doing. So just very briefly, my journey, very boring and straightforward. I went from high school to undergraduate medicine for 5 years, and then I've done all my training at Westmead Hospital. I did 1 year's SRMO, and then I started O&G training and haven't taken any time off, and now I'm at Auburn as a senior registrar this year. So just one little thing about women in O&G, and probably one of the biggest reasons why I chose it. There's a lot of women doing it. It has the most female fellows out of any surgical specialty, and Randscope in 2019 of the fellows had gender parity. And if you look at the numbers now, so in training, 83% of trainees are female, and 5% of female trainees work part-time. 18% of female trainees took leave outside of annual and study leave, and this is actually mostly maternity leave. So if you were interested in doing a surgical specialty, but you do also want to prioritize having a family while you still can, and the risk of complications are low, you might want to consider O&G, because it is very, very common for trainees to take maternity leave for 6 months, 12 months and come back even part-time. And because it's so common, even male trainees, well, we know lots of people in our network, the male trainees who've taken paternity leave for 6 months or 12 months even, and it doesn't really affect your career as much as it would in, say, general surgery. And then finally, just one last bit of advice. In general, and especially for O&G, make sure you don't hate it and consider GP first. So this is only half a joke. So keep your mind open. What specialties are like as a medical student is completely different when you're the registrar or the fellow or the consultant. Same things as what James said, try as many things out as you can, and at least rule out what you don't like. And even if you don't find one that you love, at least pick something that you don't hate. And my advice to you is all to consider GP first. So when I was in med school on the first day, we were all told, by the time you finish training, 50% of you will be GPs. And back then we all thought this was a bad thing, but it really is not. It's a good thing. So every single person I know who ended up doing GP straight off from med school or dropped out of some other specialty training to do GP love their life, or at least their lifestyle. They get to enjoy the money that they make. They have time for their friends and family and hobbies. Really give it a good consideration. Even though I'm trying to sell O&G, consider GP too. And then do something out of work. So find a hobby or something. When you're working long hours and trying to study or trying to get onto a training program, it can get very boring and monotonous. It's very easy to get depressed and lose enthusiasm and interest in your work and your life. So for me, that was going to the gym. And in terms of life advice, 5 a.m. is probably the best time to go. There's very few people there at the gym at 5, so you don't have to share your machines and weights with other people. And then the best thing is it's better than going at midnight, because you feel a bit safer, because eventually the sun rises. And then lastly, make time for your family and friends. So it's a long and winding journey, which is what I wrote in my HSC essay, but no, really, it really is a long and at times difficult journey and in medicine and in O&G training. Make time for your family and friends so that you don't lose perspective of what's important in life, because at the end of the day, it is still just a job and it has an end date to it, whether it's retirement, injury, lack of interest or something else, whereas your family and friends will always be there. That's it.
Great. Thank you so much, Hilary. So I'll, I guess, open it up to the board, to the room. If people have any questions, feel free to send it through on the chat or just unmute your mics and ask.
Well, I must say that both what James have said as well as what Hilary said was exactly what most of us did. What James have categorized is, when I look back, is what I actually subconsciously did in terms of choosing where what I would want to do and what all the other options are. And then what Hilary talked about in terms of the actual particular part of the training is really, really important. I can share with you that when I was in Auburn for 18 months as a registrar. And at the time you were on call. There's only 2 registrars, and one of you are on call 24/7 Monday, Wednesday, Friday, Saturday, Sunday, and the other one on Tuesday and Thursday. So you're on call anytime. So you literally come to the hospital, and then sometimes you stay in for a long time. And I found out that there was a previous doctor who actually have at the back of the hospital have a little gym. And every time I get called in the middle of the night and I can't go home because I'm augmenting somebody and I have to do a forceps or waiting for theater, I just go to the gym and do it in the middle of the night and come out and get the baby out and then go home. So you got to actually have some perspective and enjoy the life. And I did 1.5 years in general practice, like what Hilary said. And when you were in doubt before your training, go out, see the real life, work in a small community place, or at the time I decided I should be in Campbelltown, next to the mall where there's a lot of drug addicts and all sorts of problems, so that I can see the right perspective. And after 1.5 years, I found that, no, I want to come back to the ONG. It's much safer. That's when I would not go back. Yeah.
Thank you, Sang. I've got some questions on the, I think Hilary's just messaged, but I guess for everyone, if you don't mind elaborating for the ONG term, in whether you were able to do an ONG term in PGY 1, then get an SRMO job, or not. And then for both James and Hilary, is it achievable to do ONG training with young children, or will I never see them?
People have done it, haven't they? So people do it differently. So some people have chosen to do it part-time, which makes it more sustainable. But if you try to zip through it as fast as possible, then you probably won't see your children. It'll be a lot of childcare, a lot of nannies. Is that fair to say, Hilary?
Yeah, but to be honest, like say, for example, in ONG, most female trainees that have a long-term partner, once they've passed the exams, everyone goes on maternity leave. And it's the same at every hospital everywhere. And so it's really quite acceptable to do it.
I can add on to this. I have one of our staff specialists at Westmead Hospital. She has, how many children does she have? 3 or 4? 4 children. So she was a medical student when I was a junior trainee. And then she only finished recently. And it took her 10 years to do it because she was having babies and she was on maternity leave and she was having that. And because she reached the maximum limit and the hospital have problems sort of maintaining her, she decided to do, she's obviously a very capable person. She decided to do a PhD to fill in her time. And she managed to finish it only a few years ago. And she took 10 years, which is the maximum that the college allows her. And in that meantime, she's got 3 children. So it's possible. Yeah. It's all a question of how much you want to organize yourself and how determined you are. And yeah, she get a lot of research grant from the college just to do what she does. And the college even interview her. You can look up the website where the college interview her and say, how does she go through this? So it's possible, and she's in Westmead.
Nice. You just got to be strategic about it, I guess. Yeah.
You got to be motivated. You got to know what you want, and you tell people what you want.
Yeah, definitely. There was another question which James and Hilary already answered on the chat, which is whether or not med school marks come into play in terms of the getting on training programs. And I think the general gist is, if you come first in your grade or get a particular award for ONG, yes, but otherwise not really. It's more the CV and the interview and what you do after you start work.
And neither of us had those points, I don't think. Is that right, Hilary? No.
No, just do your job and hard work. That's what got me here.
No, we didn't have those points. No.
That's very reassuring for those of us that weren't the top scorers in med school.
No.
You will find that most of the top consultant obstetrician and gynecologists do not have an honors at the back of the
Someone should do a study of kind of like the people who get those awards, what they end up doing. And
definitely medical specialties.
Yeah, because I do feel like there's a lot of anxiety like amongst medical students or as a junior doctor when I think about things. Like sometimes I'm thinking, oh, I regret not studying harder in med school because now I feel like I'm behind. But I guess much of what you're saying is it's honestly on the job, a lot of things, and kind of how you satisfy those CV criteria and being a good worker and being someone good to work with plays a big part in it.
Yeah. And no one cares what you think for 2 years. Like no one asks you for your diagnosis of anything for 2 years. They ask you to photocopy stuff, right? And they ask you to write discharges and they ask you to be efficient. So nothing that you learnt for years, it plays into the first 2 years at all.
And I mean, even in terms of the CV, that's why I meant work smart, not hard, but also hard. Because, for example, the CV thing for ONG, there's 3 points you can get out of the whole CV marking criteria for research, but you can get half a point for a poster. You can do 4 posters, or you could write a whole paper and get 1 point for it. So if you think about it in terms of risk, effort and reward, why would you, write 2 full papers, get 2 points? We can do 4 posters and get the same 2 points.
And that's one of the things where I think it is really important, whatever career you want to choose, start having a plan when you were still just a medical student. For us doing research, I'm dealing with a lot of general research in Westmead. I'm the director there. Now, we'd rather have medical students who are keen and pick them up to do research because their research are a lot more meaningful because you've got a lot of time. Once you are working, it is hard. It is hard to pin you down and get some work done. So I think the planning from very beginning is really, really important for that 3 points in research.
Hey guys, just a bit of a more specific question, just about the Westmead SRMO positions, particularly for ONG. So know that they offer quite a lot of SRMO positions, particularly compared to other hospitals. Do you think there's an issue with like, oh, there's not much to do, or it's a bit harder to like compete or stand out or anything like that?
Yeah. So yeah, do you want to do this one, Hillary? You go.
No, you do it. You do it, James.
Okay.
You do it.
So there's no shortage of work, right? So that's number one.
That's why we're all laughing, because that's why we're laughing.
It's a totally fair question. You won't be sitting on your hands. But the next thing in terms of dilution of attention, that's potentially true if I have to be upfront with you. So you have 2 choices ultimately. Westmead has a lot of opportunity, and by having a lot of people, you can learn better from other people. However, it's difficult for you to shine in the pack. However, some years functionally, we've got a lot more people on quantitatively than other hospitals. So like in our best year, we got 10 of 12 people on. Yeah.
11 out of 14 or something our year. So
yeah, we knock out heaps of people versus other hospitals that have like 5 running and then they get 2 or 3 on, which I would argue is a huge underperformance, because if they're high prestige hospitals, they've already got the top 5 draft picks who are good at interviews, right? Because they should be getting 100% on. Yeah. So, but at least at Westmead, we have a certain working class mentality that we don't, we have to work for what we get. And so we're never complacent. But you do have to work very hard. And yes, because we're attracting better people over time, it is a little bit more challenging to stand out. Yeah, that's true.
But when you ask registrars, fellows, and consultants to sort of review residents or unaccredited registrars, consistently the people who rank well and are highly valued, for example, are literally the ones who do their work and work hard and are efficient, and that's it. It doesn't matter how much you know or don't know, because we're not asking you to diagnose patients or to do a cesarean when you're SRMO. It's really as simple as getting in before your registrar to do the ward round, knowing all your patients, getting the paperwork sorted, and that's going to clinic and doing all those things. And that's actually it.
Yeah, look, at the end of the day, it's always about patient. If you don't have a patient, you are in the wrong place. You really need to firstly work out what you want. And before you work out what you want, you actually need to want to not do it. And then you settle yourself. Do not look sideways. If you look sideways and look at how the green pasture next door is, you never make it. It's harder. It's a lot harder. And what Hillary told you about Auburn's roster, in Westmead, you wouldn't get that. However, the good thing about Westmead is people turn up at 6:30, okay, to do a ward round, because by 7:30, almost every day of the week, there is some form of teaching. So you will get a lot out of that you will not get it, say, in Auburn Hospital. So that's a good thing about rotating into all different hospitals. Some of them are bread and butter stuff where you want to get hands-on in Auburn, right? When I was in Auburn, because it's only 1 in 2, you know the whole hospital's obstetrics and gynecology very well. So you know how to manage all your cases. But when you go back to Westmead, you see all the dangerous things, right? If you pass through, I usually tell all the career nights in doing ONG, I say, if you pass through Westmead with so much pathology and have children's hospital next to it, which is the biggest in the state, if you've gone through all of that and you really enjoy and you have mastered through everything, you've mastered the whole world of ONG. You've seen it. Or if you've never seen it, you have heard of it. Somebody have seen it. So that's, I think, like what James was talking about, this is a working class. This is a real working class. We don't really care how good you speak. We care how good you do it and get your result.
Jeez, how did I get on then? How did I get on? That's all I got.
You're one of us, James. You're one of us.
Okay, thanks guys. Yeah, sorry, I haven't really interacted with a lot of like doctors at Westmead just because my uni isn't affiliated with Westmead. So just a final question. So I know that for the SRMO positions, for some hospitals, particularly for some hospitals, I know that they prefer to choose SRMOs who've actually like gone there for internship and residency. Would you guys recommend Westmead for internship? Like, does that play into a factor when choosing candidates for the SRMO position or anything like that?
I have a theory on this. I do a lecture for Sydney Uni about this, right? So first of all, you have a 1 in 9 chance as a New South Wales graduate to go to Westmead, regardless of if you want to or not, purely numerically, right? So
people actually want to, James. Okay.
Yeah, no, I was one of them. But there's 110 interns out of a batch of about 1,000, right? So if you want to go here or not, already you've got a 1 in 10 chance, 10% chance, whether you want to or not, yeah? So in terms of going there, it's become more and more clear that the flexibility between sites is very hard over time because there's so many good people everywhere, right? But mobility is particularly up and down the mountain, which is a very cynical way of looking at it. But the top of the mountain is RPA, and I won't mention who's at the bottom of the mountain, but it's not Westmead, right? So for you to go up the mountain, so you start mid-tier and push up is very hard because they're going to take their own people. But if you want to go down the mountain for whatever reason, and it's not a quality issue, it's purely a prestige issue. This is just market value more than any actual intrinsic value. Yeah, it's way easier to go down the mountain. So at Westmead, you're basically in the top third, I would say, from a prestige perspective. But I would say it'd be very inaccessible to go up the mountain regardless of quality and merit alone, because it's a very, very uphill battle. So wherever you want to work long term, try and get internship there.
But I would still recommend internship and residency at Westmead. You have to be prepared to work, like you work like a dog, to be honest, but at least they pay overtime now. And you will come out the other end being confident, unlike some other places I won't name that might have a name, a good name, a reputation, but they also put, cannulas in the jugular vein.
There's a question about international students. That's a huge topic on its own. I would recommend there's an international students network on Facebook that do a lot of data about that. Your biggest issue as an international student is getting an internship. You can make it all work from there onwards. So look, if you're an international student and you're worried about things, don't even worry about specialty yet. Your ultimate goal is to get in the door at an internship level at a public hospital, and then you can work the rest out.
Cool. Any other questions from the crowd? last chance. All right. It sounds like there's no questions at this stage. Well, thank you again to our speakers. Thank you to Sang, and thank you so much to James and Hilary. Honestly, your talks were so informative, I think as a medical student level and junior doctor level. And yeah, I guess thank you to people online as well for asking the questions and having a conversation about these difficult questions at times. So if that's it from everyone, okay, it's just people that saying thanks, then we'll conclude the talk here, and the talk will be online on YouTube on the channel, and we'll send out a link. So yeah, thank you so much, and I will now log us off.
Thanks very much.
Thank you.
Bye.
See you later.